Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPV disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. So, hi, welcome to Guts and Glory. My first guest on this, and it's really my pleasure to have Dr. Peush Sahani. Now, we've been together as from being from the same alma mater, the All India Institute of Medical Sciences, and he's been there since yeoman years. I think more than 30 years he has spent at All India Institute and just recently
47,
retired.
Sadiq.
How many?
47.
47 years at All India Institute and recently has retired as the professor and head of GI surgery and chief of KL uh, Center for Medical Education, Technology and Innovation. Of course, Piyush wears many hats. He has been on various committees and he's been the editor of the National Medical Journal of India, again, since the time I remember. And he's running the show on that since how many years, Piyush?
So if you say the first issue onwards, 37 years associated with the NMJI.
And he's been the president of the World Association of Medical Editors. So, welcome, Piyush. Uh,
Thank
uh,
you, sir.
you know, I I know you since many years, and I know that all people in this country have your name synonymous with extrahepatic portal hypertension and the work you have done in portal hypertension over all these decades in at All India Institute. So I thought, who better than you to speak to us and give us insights into this very complex disease of extrahepatic portal venous obstruction. So let me start with I know that, when the Department of GI Surgery at AIMS was instituted, you were one of the foundation pillars of that department. So talk me through this, that how did that happen?
I was in surgery unit 4 and in 1985, May or 1985, I actually had my exit exam for the Master's of Surgery and I flunked the exam. I was sitting and brooding over having flunked the exam. So, interestingly, I think Dr. Nandi was very keen on setting up GI surgery. And what Dr. Nandi said is that, do you have anything to do? I said, no, I'll sit and read for the next few months till the exam comes up again. Do you want to do something? So I said, yes, I can't read continuously. So he said, I'm starting GI surgery. Come and join me. And there's no salary, only work. So essentially, that's how it all started, 20th of May, 1985. The AB2 ward, the last two cubicles in the gastroenterology ward.
We know that in India, many units or big institutions pick up certain areas of work and then they, become the experts, opinion makers on that. So tell me how portal hypertension or EHPVO came as the primary, most important area of work for this unit. And it's been known as the one with maximum experience and expertise in this. How did it come about?
So I think this is obviously much before the time that I started working with Dr. Nandi. I was an undergraduate probably at that time when he came and joined the All India Institute. And at some point in time, there was obviously a conversation between him and Dr. B.N. Tandon. Surgery Unit 4 used to provide surgical backup to gastroenterology. So GI bleed was one focus, upper as well as lower, and because of that came the interest in portal hypertension surgery. And by the time GI surgery unit was set up, uh, one of the areas that Dr. Nandi was looking after within surgery unit 4 was GI bleed and portal hypertension. So when GI surgery unit started, Dr. Nandi said we should do things which other people do not do. And so we picked up 10 diseases, and portal hypertension was one of them.
You think the flip that portal hypertension and surgery got, and the surgical unit got such a large volume, was because of the non-development, or uh, not that aggressive endoscopic treatment, which now we see for these varicose management?
Yes. So at that point in time, diagnostic endoscopies were available. Ultrasonography had just come in.
Just come in.
CT scan of the head came in while we were residents. So most of these patients used to have what today would be called primitive investigations. A barium swallow, if they came in at a time when endoscopy was possible, then endoscopy. Sclerotherapy was not there, and variceal banding came much later.
Much later.
Yeah. So a lot of these people in the emergency would come in, would get on to what today we would call would be substandard therapy, and would then, if they didn't stop bleeding, get a zinc stuck in tube put in, and then often be referred to surgery. And the only condition that one hoped was that you would find a splenic vein. If they had previously been worked up,
Yeah.
a splenoportovenogram would have been done, because
Direct
ultrasound was
function.
initially not
Yes, please. Yeah.
developed. And
Yeah.
that's how the diagnosis used to be made. Um, Obviously, as things went along, things progressed, and so there weren't very many alternatives at that point in time.
Yeah. So, Piyush,
Little thing that I mention to people when we talk about non-cirrhotic portal hypertension is that an astute clinician, Professor K.L. Vig, noticed this set of patients who used to do well despite a variceal bleed, didn't develop encephalopathy, did not decompensate. And that's how he started looking at these patients. While extrahepatic portal venous obstruction was one of those entities, the other was non-cirrhotic portal fibrosis, which actually got described initially at the All India Institute of Medical Sciences. And
so tell me a little about this, because the non-cirrhotic portal hypertension had these two main entities, and as you are just explaining that the investigations were primitive, and we had to make a clinical diagnosis at that time. So just briefly, because for the people who are listening, I would be keen that they understand that what would be the clinical differences and the geographical prevalence of these entities, because these are not very often seen in the West, and these have been mainly described from this part of the world. So, can you just throw some light on EHPVO, NCPF, clinical diagnosis, and how?
yes, so largely the younger patients were extrahepatic portal venous obstruction. They had moderately large spleens. In contrast to patients with non-cirrhotic portal fibrosis who used to be generally a decade older. Their spleens were much larger. They would often, not all of them, but a few of them, would develop mild signs of decompensation following a bleed. In the sense, there would be a history of pedal edema in a previous bleed. There might be a history of mild abdominal distension at the time of the bleed, following the bleed for a few weeks, and then it would settle down. They won't give you a history of encephalopathy. There won't be a history of jaundice. Uh, and this is what, these were the kind of subtle signs that one was trying to pick up in the history and in the examination. On investigations, the hemogram would often show pancytopenia or features suggestive of hypersplenism. So retic count is was our go-to to say this is hypersplenism. So a raised retic count with one of the low elements in the absence of a GI bleed a low hemoglobin would also count. Otherwise, a low total count and a low platelet count, either one of them, and we'd make a diagnosis of hypersplenism. Um, Ascites was not seen in patients with extrahepatic portal venous obstruction. The only patients in whom we did see ascites were very young children. Children below the age of
Okay,
5,
HPV.
EHPVO. Below the age of 5, you would, 6 or 7 sometimes, you'd see their bellies distended. Palpated them, they had large spleens, and a few of them would also have a little bit of fluid. But this fluid was often following an episode of GI bleed. We didn't go very often to pediatrics, but we did. It was not that it was. We never went to pediatrics. We used to get calls from pediatrics as well for patients with GI bleed who reached them. Unfortunately, pediatric endoscopes came in much later. So pediatric endoscopy and sclerotherapy and all those things came in much, much later.
So, you guys took up these challenges. You operated on these patients, and I remember that I think in it was Annals of Surgery, 1994. Uh, am I right? 1994 was the
Correct.
time that seminal paper from All India Institute came, which talked about proximal linear shunt and extrahepatic portal venous obstruction, and it was
Correct.
like I mean, a game changer. Uh, an Indian study of this magnitude being published in Annals of Surgery. So, what impact it had? How did you go about, you know, uh, putting this together? And what do you think was the impact of this? And I'm going to delve a little bit more on this paper, but just to how did it? Because it was quite a seminal event as far as all academic surgical GI people are concerned.
Yeah. So I think Professor B. N. Tandon was very interested in the disease condition, and he, in fact, organized an ICMR supported seminar on portal hypertension in India. And I don't know if you've seen the book, the small little book that was brought out following that seminar, which was on portal hypertension in India. This happened uh, before we became residents in surgery. And it was largely gastroenterology who were involved with this activity. But there was a lot of interaction between the Japanese at that point in time, Kunio Okuda especially, who was a good friend of Dr. B. N. Tandon, and Dr. Nandi. And they also, there was a book on idiopathic portal hypertension written by the Japanese, Kunio
Yes.
Okuda and Omata, which had a lot of contributions from our pathology department, Professor Naik specifically, and Dr. Nandi and Dr. B. N. Tandon. So people knew that portal hypertension surgery was being done in India. In 1988, we published a paper in the BMJ, in the British Medical Journal, on the experience of patients with extrahepatic portal venous obstruction. This was adults and children. And I still remember that the days when we used to, Girish and I used to sit down with an ordinary chart paper.
Yes.
Uh,
No
and
Excel sheets at that time.
yeah, no Excel sheets at that time. So on a chart paper, we put down all the data and then manually did a live table analysis and produced uh, a survival curve for the BMJ paper. Following that, I think one of the things that we all felt was that the general focus in the West seemed to be on children and young children, while we didn't seem to see those young children, possibly because access to healthcare was an issue. And a large number of these children who had portal hypertension, extrahepatic, with extrahepatic portal venous blocks were located in places which did not have good access to
Good
healthcare
access to
facilities.
healthcare.
So they tended to present much later. So our mean age of patients who presented to us was about 19, with extrahepatic portal venous obstruction was 19. But then
Hmm.
we started looking at the patients who were coming to us, and systematically analyzing the data that we had collected. Interestingly, Professor Nandi used to, very early on, used to fill up a proforma, a 4-page, 4-leaf proforma, 2-leaf, 4 pages, both sides, proforma himself, till till we started the um, GI surgery um, unit and then the department. He used to do it himself when he was in Unit 4. He used to carry in his white coat an index card for entering some basic details of the patient with portal hypertension. And these index cards and those proformas which were filled up used to be the places where the go-to places for the data. The
Right.
follow-up was also entered in these. And for the follow-ups, every patient that he saw in the OPD, he would write down on the card whatever was the follow-up of the patient and then come back and fill that up in the proforma. These performers used to be in his office and they weren't available in the duty room till such time as we started the GI surgery unit separately. And then these were then accessible to the residents. So these were what were used to. So there weren't any computerized
Right.
data. There were no
Right.
in hospital information systems from which you could get data. If you needed more information, you had to go down to the medical record section and try and retrieve the case sheets. And so that's how that paper in 88 got written up. The 94 paper was more about children because we started seeing uh, older children, but children nonetheless. And we thought that a lot of the literature suggested that people needed to have a certain minimum size of a splenic vein. They needed to grow up, and that's only when you should operate these patients,
Right.
or
Right.
they tend to grow out of their disease.
True.
And this is something that Dame Sheila Sherlock propagated a lot, that children grow out of their disease. Interestingly, we operated on a patient who was a patient of Dame Sheila Sherlock and had continued to bleed for close to 14 years before we operated that patient. He received over 100 transfusions and
Didn't grow out of it.
no, did not grow out of it. So that was the background, and that was the intent, to show to people that these children did not grow out of the disease. And the adult disease was, it's the same children who were growing up and becoming
Yeah.
adults. And very few of the adults were actually acquiring the disease in adulthood. It was
So,
largely children who were growing up.
so remarkable about 160 patients, I think, and
Correct.
overall mortality less than 1%, and
Yes.
some emergency mortality of 10% or something like that.
Correct. That's
Uh,
been the general figures even up till now.
yeah.
Uh, we sometimes go below 1%, we sometimes touch 1%. But mortalities are extremely rare, but they do happen. It's not that they don't.
So tell me, Piyush, a little bit on, since you've seen so many over all these decades, I mean, we are still not clear about the etiology of this, that we don't have, we speculate a lot on the etiology. We speculate about umbilical sepsis, neonatal sepsis, and so on and so forth as a reason for portal cavernoma formation. And then there is another group which talks about the procoagulant status of these patients, resulting in EHPVO and problems. So throw some light on this, that, what, in your experience, is the cause of portal hypertension in these people?
So, Sadiq, we still don't know what is the cause. So neonatal sepsis, umbilical sepsis, happens in less than 5% of patients. So that was a very, very small proportion, if at all, of the cause of extrahepatic portal venous obstruction. Um, so a lot of speculation. Was it intra-abdominal sepsis? Was it portal pyemia at some point in time early on in the life of the child, which led to the extrahepatic portal venous obstruction? But we could really never put our fingers on it. Coagulopathy you mentioned, and coagulation disorders, prothrombotic disorders. But Girish, as a part of his PhD, looked at prothrombotic disorders in patients with extrahepatic portal venous obstruction and did not find a very high incidence. I don't remember the exact numbers, but I do remember that around the same time that he finished his PhD, there was a paper from Mumbai, or a little later maybe, which suggested that the incidence of prothrombotic disorders was about the same as what was seen in the West. But unfortunately, in our patients, we never found that incidence. We always seem to think that the Mumbai patients seem to be a little more westernized than the Indian patients, because they seem to get data which was more akin to data that came out from the West. But unfortunately, we never found, we could never put our fingers on the exact etiology.
But again, considering your focus that treatments should be cost effective, the kind of patients which are coming in, do you think we have enough data to say that this 100 patients have had all this workup, and then in that, in contrast to the study from Mumbai, which would have had all patients having done these tests, and therefore have a sort of idea of what is the proportion of patients with these disorders which are present in EHPVO?
So my impression is that, again, this would be in the range of less than 5%, the prothrombotic disorders. It was very uncommon. Girish did a systematic study of patients with extrahepatic portal venous obstruction and non-cirrhotic portal fibrosis, and looked for, this was part of his PhD work. And he did not find it to be occurring commonly. I think he in fact published this.
Because it also has a direct relevance with the fact that whether we put them on anticoagulation, what is the post-operative management, because your patients don't get any anticoagulation,
No, we don't put
don't
them on.
get any antiplatelet therapy. So, you can say that's proof of concept that it is not there, and therefore they don't get a problem.
Correct. So there's a very small proportion of patients who used to be put on an antiplatelet or an anticoagulant. If we had an intra-op difficulty in doing the anastomosis, if there was a technical issue, if we had to dismantle and redo the anastomosis and were still not satisfied with it, then those patients would occasionally be put on antiplatelets or anticoagulants in the immediate postoperative period, and then maybe tapered off by the end of 3 months. But long-term anticoagulation, I don't think there was a single patient who got long-term anticoagulation in that whole series of about 1,200 plus patients.
So I also want to go to, there is enough data to suggest that these shunts get blocked. There's a high incidence of blockage of these shunts, especially the small shunts, and it could be up to the tune of 30 to 40% also. Now, in this paper, of course, there was no mention of shunt evaluation by any objective parameter. But over the years, when you've been doing all these shunts, and then subsequently when you have means to assess that, the patency of these shunts, what's your uh, figure? How is the patency rate of these, and what are the factors which determine the patency rate in your experience over all these years?
Very early on, did a study on shunt patency, and we looked at 60 patients and looked at different methods of assessing shunt patency. We looked at assessing shunt patency by doing endoscopy, by doing an ultrasound, and by doing shuntograms. And we compared these, and we found that a decrease in varicose grade by 2 showed that the shunt was patent. Now, if the varicose grade had not decreased by 2, the shunt could still be patent. So that was still a possibility, because on shuntogram, you would see that the shunt was patent, but there hadn't been a decrease in varicose grade. So, but if the upper GI endoscopy showed that the varices that dropped from, say, grade 4 to grade 2, from grade 3 to grade 1, or from grade 2 in the rare patients who had grade 2 varices, who had massive bleeds and who had come to surgery, to absence of varices, then it was certain evidence of the fact that the shunt was patent. We did shunt patency studies on a number of different occasions, and different methods used. Doppler ultrasound later on. Initially, we used endoscopy as regularly as a means of assessing whether the shunts were patent or not. And obviously,
Indirect
there
evidence, of course.
correct,
Yeah.
correct. And that systematic study of 60 patients in whom we did shuntograms as well. And we never seem to go beyond the 18 to 20% range of shunt blocks.
Okay.
So, but every patient who had a shunt block, interestingly, did not rebleed. So only about half the patients who had shunt blocks would rebleed. So
Mm-hmm.
if you looked at the rebleed rates, they were lower than the shunt block
Shunt
rates.
block rate.
So shunt block rates seem to be higher. Now, was this because there was some form of collateralization happening? Was this because some natural shunts were opening up? Difficult to say. We were never able to demonstrate large shunts on splenoportovenograms or later on Dopplers in these patients. But occasionally, not across the board in all patients, but occasionally we would come across a patient who would have a large liner renal shunt, but
Yes.
despite that, continue to have a GI bleed.
GI bleed.
So obviously, evidence of the fact that they hadn't been adequately decompressed, and we would then offer them a proper proximal splenorenal shunt with the removal of the spleen. The contribution of the spleen in all this was something that was a matter of debate.
Yes.
Uh, Professor Kunio Okuda from Japan was very convinced that a very large spleen contributes to hyperdynamic circulation and contributes to the portal hypertension. He felt that, in fact, the entity of non-cirrhotic portal fibrosis, which the Japanese called idiopathic portal hypertension, had a large component of a hyperdynamic circulation causing the liver condition. Um, we, I don't think he ever proved it, nor did we ever be able to prove it in patients with extrahepatic portal venous obstruction or non-cirrhotic portal fibrosis. But this was definite that our patency rates were in the range of about 80% and rebleed rates in the range of about 10%. So about half the patients with blocked shunts would rebleed, not all of them.
Right. So, this paper talked about patients who are bleeding, right? And then
Correct.
this huge thing came from All India Institute Surgical GI Surgery Unit that we should be offering prophylactic shunts to patients with EHPVO. Now, that was quite dramatic that such a major surgery to be undertaken at that time for these people who are not bleeding. So I know there are several justifications for that, but I want to hear from you that how did this come about? And what about the ethical aspects of subjecting these young uh, boys and girls to a major surgery with a possibility of mortality?
I think the concept started off by the occasional patient who would come in to the OPD who would not have had a bleed but had high risk varices, grade 3 or grade 4 varices. And we would say that, he hasn't had a GI bleed, so why should we intervene? And this patient would then go back home and then come back to the emergency in a hypotensive, shocked state, would require multiple transfusion to resuscitate. And we'd say that, we saw him 6 months ago and we could have actually done an
Mhm.
elective procedure for him. And now here's this patient who's now in this state where we are going to have to do an emergency procedure for him. And, sometimes in some of them, we were successful in controlling the variceal bleed by sclerotherapy. These were early days.
Yes,
And in the others, we were not. And therefore, they ended up with an emergency shunt with a 10 times higher mortality and morbidity.
right.
And so the argument that why not operate upon these patients? Then there were these occasional patients who came with massive spleens who had these very painful spleens. And you tried to take them out, and you would have encountered them yourself. They were all plastered to the diaphragm because of the splenic infarcts that they'd had and the revascularization of those infarcts
Yeah.
from the
Perisplenitis. Yeah.
so uh, again, these patients, there were very few, but they were there, who had this, painful spleen syndrome, if you want to call it that. And we thought, these people, they they're going to find it very difficult to keep going on like this. So might as well take out the spleen. And if you're taking out a spleen in a patient who had high grade varices, you are actually obliterating one possible source of portosystemic connection. And we
Right.
thought it wasn't justified. So these were the two things. The first one more important, the second one less important, where we occasionally started intervening. And then we systematically decided to offer a prophylactic shunt to patients because they seem to do well.
This prophylactic shunt you're talking about, I know that time and that era, I mean, this is very provocative, but uh, it was a era of paternalistic medicine,
Yes,
especially
absolutely.
at All India Institute. I mean, we would just tell the patient, you need this, and they'll say, thank you, and get admitted whenever you give them a date and are thankful that they got a date. What do you think would be your ability to convince patients in this time and age for a prophylactic procedure of this magnitude? You think many people would take it?
So I think the argument that we gave to these patients, there were a few patients who refused. They were well-to-do. There were patients who lived in the city of Delhi and said, "Can't we come back if we had a problem?" And we said, "Yes, you can." But a patient who said he came from 400 kilometers, patient who said that the last time he had he had a problem, it took him 2 days to get to a hospital. In these kind of patients, we would explain to them that this is a risk that you have. You have high grade varices. The likelihood of your bleeding from these varices is high. If you bleed from these varices, there is a small percentage that you could die from that episode of GI bleed. And obviously, it's much less than in patients with cirrhosis, but it's not negligible or absent.
Yes.
Today, probably what Professor A.K. Basu in Calcutta saw over a period of time, 25 patients followed up with extrahepatic portal venous obstruction who refused surgery for one reason or the other. The end of 5 years, all were dead. That
Yes.
would probably not happen today
Yeah.
because our healthcare facilities are much better. But still, there is a proportion of people who would end up with morbidity, definitely, possibility of an emergency shunt. So all these things were explained to them.
And now, in the era of great endoscopic interventions which are available to control bleeding and also varices as a prophylaxis, where do you think, I mean, how many you would be doing now prophylactic shunts as opposed to, offering them prophylactic endoscopic therapy?
So the number of patients who are undergoing prophylactic procedures has obviously come down because as healthcare has improved, patients tell us that they have access to a blood transfusion facility and they could get to a tertiary care hospital in a reasonable period of time. We would say that that's fine. They don't need to undergo a prophylactic procedure. However, to put a person on a prophylactic endotherapy schedule in patients with extrahepatic portal venous obstruction may not be absolutely the right way to go about things. I don't think anybody studied it systematically. We've done a case control study in which we found that patients who had endotherapy had a much higher incidence of portal biliopathy.
I want to now talk about the surgical aspects because there are a lot of people who would be hearing about this. I remember in my residency days, we would be thrilled that there's a portal hypertension going on in one of the units. And when we go there, we would get a very peripheral view, but there'll be a lot of blood all around. There'll be blood on the floor, and portal hypertension surgery is going on. And that was the kind of signature of portal hypertensive tension surgery going on in a operating theater. Of course, the scenario probably is much more different. What do you think has changed in terms of technique and our ability to do these surgeries with minimal blood loss as compared to what it was at that point of time?
I think the first and foremost is the fact that we've all gained experience and we passed on our skills to our younger colleagues, and they've gained from the experience that we've gained. Number one. So we as residents used to scrub in for a case in Port Elizabeth for a shunt surgery, and we were pretty certain that lunch was out of question. If evening tea you'd get, that'd be a great thing. But you often wanted to have dinner, and most of the times you used to get to dinner. But there were times when you did not get to dinner as well, and all that you had was a small bread omelette in the cafeteria
Cafeteria.
because the mess had closed by the
24-hour
time
bread omelette.
by the time you finished the patient, shifted the patient out to the ward. From there, we've obviously progressed hugely. I think we've learned how to remove the spleen in a more bloodless manner. We've learned of the planes that exist and where we avascular planes that exist into which we can go. We've also have access to good energy devices, a lot of which allow us to control the smaller vessels and therefore then control some of the larger collaterals by our conventional ligate and cut methods. We've also learned that over a period of time that there are some places which are more prone to bleeding, and therefore you need to go slower, and there are other places where you could go faster and therefore and even then not encounter bleeding. So I think the technique has got refined as things have progressed. Planes have become clearer. Routes to access the splenic vein have become clearer, and general surgeons usually did not have much access to or much exposure to vascular dissections and vascular anastomoses. And that's an area which students in MCH who've done MCH and GI surgery are becoming more and more confident of. And that itself has also helped. So dissecting the splenic vein off, finding the splenic artery, tying off the small tributaries. And as you go older, using a loop helps. And I would suggest that younger people should start
Should
using
also.
loops much
Yeah.
better. And that would make life easier for them as well.
So I often tell my people when I'm doing this surgery that, you guys are in an era where you have all these gadgets with you, and I've seen each collateral being ligated and divided and taking enormous amount of time and, of course, losing a
Absolutely.
lot of blood. So tell me the prerequisites that you look for when you say that, yes, this is a patient I'm going to take for a shunt surgery, and this I'm not going to take for a shunt surgery, EHPVO?
So if you would have a patent splenic vein, we are happy. Obviously,
Size?
clinically, and, sorry.
Size is any criteria?
Yeah, so in an adult, in 8 millimeters is fine for us. We've anastomosed 6 millimeters as well. We tend to try and dilate the splenic vein. Two ways of doing it. One is to, after you've dissected the splenic vein off, divided it, you just use a mosquito forceps and gently pull the vessels away from each other with the mosquito forceps within the splenic vein. And the other is that if you've got the dissected the splenic vein off and you have both ends closed, then use a small syringe with heparinized saline and very gently put in a fraction of an ml of fluid into the splenic vein. You can see it distend. Don't do it too vigorously, because if you do it too vigorously, you could get all the ties which on the small tributaries
Yeah.
which were coming off the pancreas, coming off, and then you have to resuture everything. 6 millimeters is fine with us. The smallest vein that we've anastomosed in a child is actually 3 millimeters, and but we prefer anything about 8 to 1 centimeter. 8 millimeters to 1 centimeter is good for us. And we think that an 8 millimeter shunt would serve the purpose in a patient with extrahepatic portal venous obstruction. In patients with extrahepatic portal venous obstruction, if we had an 8 millimeter vein, we would do an angulated cut and do an angulated anastomosis. So the anastomosis itself would be a centimeter or maybe even 11 millimeters or 12 millimeters. If we had a larger vein, in patients with extrahepatic portal venous obstruction, we'd be happy to go ahead and do a much larger anastomosis, even a 15 millimeter or a 17 millimeter anastomosis. But in patients with non-cirrhotic portal fibrosis, we had a very large vein because these patients had a very large spleen and had a hyperdynamic circulation. We would tend to trim, or I won't say trim, down the vein down from a little higher up to this place where we're going to anastomose to about a centimeter. Despite that, we have, at least in a few patients, I can count them on my hands, but we've seen on Doppler ultrasound the anastomosis expand to as much as 3 centimeters, with as much as 2.5 liters of blood flow going through that anastomosis. And these patients then tend to develop a mild encephalopathy, minimal hepatic encephalopathy, as we would call it today.
So I want to take up your access and approach thing. And I've seen that, and I had also trained in that approach, which is the thoracoabdominal approach, opening the chest, the diaphragm, and then having this fantastic exposure and this thing. But then when I moved to SGPGI, Lucknow, we modified it. And we were happy to do it by a subcostal or modified kind of incision. I always used to wonder that there is an element of morbidity opening the chest. We are also cutting the rib cage. You still would recommend the same approach, or you also have modified that approach to go away from a thoracoabdominal approach to a purely abdominal approach for this procedure?
So we continued to do the thoracoabdominal approach for one major reason, and that was that we wanted to train people in doing shunts. And we thought that for a trainee to try and struggle with a spleen which was large, which was adherent to the diaphragm, learn the thoracoabdominal incision, and once they were confident enough, when they had trained, when they went back, they could change to a subcostal incision, reverse hockey stick incision. We've used these incisions in children more frequently than we've used it in adults. But in patients who don't have a very large spleen, we have used the subcostal incision. But as a routine, as a way of teaching the procedure, we still prefer to do the thoracoabdominal incision.
So, I mean, you said training, and I said you all are experienced and you can train them in another way of doing it. But as you said, that you prefer to continue to do that because there's a process, there is a protocol, there is a design by which this operation is performed, and so there is a consistency both in the way you do it and the results. So I want to quickly ask you about 2 or 3 other modifications in shunts. So there is that side-to-side splenorenal shunt by Dr. Mitra. Then there are makeshift shunts, which I think Richa has talked about and published and all. And there is also an option of uh, mesocaval shunts in this if the superior mesenteric vein is patent. Now, what is your thought about these options? Are they open? Would you choose them over a proximal lineorenal shunt? And if you choose them, what would you be the scenario in which you would think it suitable?
So, as a first preference, always a lineorenal shunt. If we don't have a splenic vein, then we would consider doing a mesocaval shunt. We had done mesocaval shunts in the past on a reasonably regular basis as a second line therapy. So patients who had a lineorenal shunt, who blocked the shunt and rebled, and we didn't have at that time endotherapy, In those patients, the option was doing a mesocable shunt. So that was the second procedure that used to get done in these patients. As a first choice, a mesocable shunt, no, primarily because their shunt block rates are a little higher. They tend to block more often, and the rebleed rates are a little higher with a mesocable shunt compared to a splenorenal shunt.
So you're talking of direct or interposition?
It's both. Both. Even if you do a graft, even if you do a direct mesocable shunt. So in children in whom the splenic vein was not available, the superior mesenteric vein was available. We have done in a few patients, maybe 10 or 12. I don't remember the exact numbers, but small numbers. We have swung up the inferior vena cava or the iliac vein and done an anastomosis directly to the superior mesenteric vein. We've also mobilized in adults, young adults, the superior mesenteric vein and the inferior vena cava and brought them together and done a direct mesocaval shunt. But there are patients in whom we've used a synthetic graft, and we've also used autologous jugular vein grafts for doing these mesocaval shunts. So all options have been used, but all of them have a little higher block rate and rebleed rate compared to a proximal splenoid shunt. So if a splenic vein is available, first choice, proximal splenoid shunt. So that's as far as mesocaval shunts go. The side-to-side shunt we've never done, primarily because patients have a large spleen. The data that came from Dr. Mitra and later on from the PGI group suggested that the spleen size did shrink. Hypersplenism did reduce, but it was not zero. In the sense, if you remove the spleen, all the problems related to a painful spleen, a large spleen, all those go away, number one. And number two, hypersplenism, which is present in about 45% of these patients, in our series at least, that is taken care of. Now, there's been this huge argument about symptomatic versus asymptomatic hypersplenism. And patients who are asymptomatic as far as their hypersplenism is concerned, should you should you preferentially do a splenectomy in these patients? So,
or save the spleen for that matter.
Yeah. So some people have argued for saving the spleen by doing the side-to-side shunt that Dr. Mitra used to propose. Now, the saving the spleen, a third of patients still who've had this procedure still don't have a decrease in the size of the spleen, and the hypersplenism doesn't revert to normal, number one. Number two, so we don't know what will happen to them over a long period of time, 10 years, 15 years, 20 years. Or if the shunt does get blocked, we don't know what will happen to it. That's one. The second is that these spleens remain there and they are painful in some of these patients, and therefore getting rid of them makes a lot of sense to us. And that's why, as a first choice, proximal shunt. Given a choice, superior mesenteric vein available, splenic vein not available, mesocable shunt. In a mesocable shunt, first preference for a direct one, because that has the least block rate. And this is not our figures alone, this is figures worldwide literature also suggesting that those are the best ones to do. However, if you've got to pull and have a lot of tension on it, it's much better to put in an autologous graft rather than make an anastomosis which is under tension, because that is more likely to thrombose. Graft later on. Side to side, no experience, and therefore I won't say it's better or worse. Our argument was removing the spleen, so why do a side to side? Makeshift shunts. We've done makeshift shunts. Joy, in fact, in the past 2 weeks has been looking at the number of makeshift shunts that we've done. My impression was that we'd done a handful or two, so maybe about a dozen or so. But he's been able to pick out, as of date, I think 6. So these were done largely in patients who had been new preoperatively, had no splenic vein, had no superior mesenteric vein available for anastomosis.
Right.
They had large spleen. We did not have the option of endotherapy in these patients. They were coming in with repeated bleeds. So the idea was, or they had severe hypersplenism, which is symptomatic, And in these patients, we thought that taking out the spleen was definitely an option. We went and took out the spleen, hunted for the splenic vein. In the days when we did not have a Doppler ultrasound, and even in the early years of having a Doppler ultrasound, sometimes the splenic vein would not be picked up.
Yes.
With HPVs, this was common. With splenoportovenograms, this was common. Commoner, I won't say common, but commoner than in Doppler ultrasounds, that they did not show you a splenic vein, but there was a splenic vein available. And if you hunted carefully enough, you would find the splenic vein. If we did find the splenic vein, then we would go ahead and do an anastomosis. With the splenic vein, if we did not and we found a large collateral, then we would go ahead and do a makeshift shunt. The other possibility of doing a makeshift shunt would be when we actually thought that there was a splenic vein available on a Doppler, went in and found that there was no splenic vein. What was there was a large collateral. And again, then we would do a makeshift shunt in these
That
patients.
happens, isn't it? A couple of times.
It happens. It happens. Unfortunately, most of these patients, the makeshift shunts tend to block off over a period of time. Richa series children, maybe they do better with makeshift shunts compared to adults. We don't know, but we haven't done that many. But yes, given a choice, nothing else available, we have a collateral which seems to have a good vein, a good wall. We would go ahead and do a makeshift shunt.
IMV, not necessarily collateral. Suppose there's a IMV which is patent. You think it is going to decompress the whole system?
So I won't do it for a patient with portal biliopathy. It may not decompress the complete system, but if you have nothing else available, why not try it?
Right, right.
We haven't done any one of those, but I must say.
So I want to put a scenario.
Temporarily.
Many
Okay.
times this could happen, and because it would be a learning from you to dissection of splenic vein sometimes is difficult from the pancreas, and there is sometimes element of pancreatitis, venous inflammation, and it becomes difficult, and there is an injury to the splenic vein, and you land up just ligating it, and you are not able to do. So if you have a scenario like that, what would you recommend at that point of time that you've lost the
So,
splenic vein now?
so if you lose the splenic vein, it does happen occasionally, but if we lose the splenic vein, our first choice at that point in time is, because we use a thoracoabdominal incision, is to go ahead and do a splenectomy and a devascularization. If you do a good devascularization, your results are not bad. You get a rebleed rate of about between 20 to 40%, depending upon which series you look at. When
Yes.
we looked at our own patients, we find that it's not that bad. It's only about double that of the about 20 to 25% rebleed rates. So about double that of a shunt, a proximal sphenoidal shunt. So we would go ahead and do a good devascularization. Lower 7 centimeters of the esophagus, half of the lesser curve, and 2/3 of the greater curve. Remove the spleen. If the patient came back with a rebleed, we would reassess for the presence of a superior mesenteric vein. If present, young person, we would offer a mesocaval shunt. Today, in a 40, 45-year-old, we would say go ahead and have endotherapy done.
Yeah.
But
Eh,
if it was a 16 or an 18 or a 20-year-old who's got a long way to go and doesn't have a procoagulant disorder, we would go ahead and do a mesocaval shunt. But the number of mesocavals that we used to do has come down dramatically from the time uh, good endotherapy became available. If a patient comes back with a rebleed, we often
yeah.
now suggest that they go ahead and have endotherapy. A
Endotherapy.
second surgery is not something that is very palatable to a lot of patients.
Because I've had these situations many times that, A, the splenic vein, which has been thought to be that on imaging, is not there, and they're just collaterals over there. And then I had to change it to a devasc procedure. And similarly, as I said, injury to that. Uh, Piyush, talk me through some of your research which your group has done on EHPVO, uh, especially pertaining to subtle encephalopathy, not florid clinical encephalopathy, and also uh, I understand that there is some information which you have on the effect of these shunts on renal function and or dysfunction, as you may call it. So tell us something about this, because we all believe that there is no encephalopathy after doing a central shunt in EHPVO. So what is there from your unit on
So,
this?
so we've looked at the incidence of encephalopathy in these patients, and patients with extrahepatic portal venous obstruction, it practically is non-existent. We've looked at subclinical or minimal hepatic encephalopathy. In the old days, it was called subclinical encephalopathy. What is today called minimal hepatic encephalopathy. There's some difference in the definitions or the way you look at it, but essentially, we at that time assessed, and this is a paper that we published in the British Journal of Surgery. We assessed the incidence of subclinical encephalopathy in these patients by doing a number connection test, a 5-pointed star, backward counting, and things like that. So some of the psychometric tests. And we found that there was a certain incidence of subclinical encephalopathy in patients with extrahepatic portal venous obstruction as well as patients with non-cirrhotic portal fibrosis. The numbers were larger in the patients with non-cirrhotic portal fibrosis compared to the numbers in extrahepatic portal venous obstruction. So that's as far as encephalopathy is concerned. More recently, one of our students looked at minimal hepatic encephalopathy as it is defined today in 16 patients, and I think he found it in 4. I don't again remember the exact figures. I'm tending to get old. But about 4, I think, or 5 patients in whom we did find evidence of minimal hepatic encephalopathy. The incidence is more in patients with non-cirrhotic portal fibrosis compared to extrahepatic portal venous obstruction. And within NCPF, there is a small group in which it seems to be even more common. And this is
Mhm.
a group which at one point in time we described as nodular NCPF. Unfortunately, we didn't
Okay.
publish much on this. In these patients who have a buccellated liver, non-cirrhotic portal fibrosis, they tend to have a higher incidence of developing ascites, pedal edema, encephalopathy, and occasionally jaundice as well. These patients we started looking at and picking up when we started coming across patients with pedal edema, and we thought this was a sign of hepatic decompensation. But we investigated them, the liver function tests were normal, the ultrasound suggested the livers were normal, but the kidney function tests suggested that they had proteinuria.
Mm.
So again, these were more common in patients with non-cirrhotic portal fibrosis than in patients with extrahepatic portal venous obstruction. We did systematically look at this problem. Dr. Arvind, who's now a thoracic surgeon, his MS general surgery thesis was on this. I did a part of the work as a part of my PhD, and we found that in patients with non-cirrhotic portal fibrosis, if you looked carefully enough, 4 out of 10 patients would have evidence of uh, what at that time we called shunt nephropathy, but
Right.
then realized later on that was not shunt nephropathy. If you investigated these patients preoperatively also they had some renal dysfunction. They had some mild
Okay.
proteinuria. What was the cause
Mm.
of this? We did not know. When we did biopsies, kidney biopsies in patients who had evidence of significant proteinuria, who developed pedal edema, we did find an IgA nephropathy in these patients,
Mhm.
and there was a complement deposition as well on the in the kidneys, in the glomeruli, suggesting that these were the cause of the proteinuria. But these were present; these changes were present even prior to the shunt being done. So it
Right.
was not as these were
Mm.
changes which are happening because of the shunt. So the hypothesis was that this is probably a part and parcel of the process of non-cirrhotic portal fibrosis. Maybe there is an autoimmune phenomenon which is causing this to happen. Maybe
Mhm.
there is an antigen which is circulating within the portal venous system, which is then moving into the systemic circulation and causing this. Maybe the rapidity with which this is moving into the systemic circulation increases once you do the liner renal shunt. and therefore you see it more in the post-operative period than you see it in the pre-operative period. So if it was a part of the disease process, you should see in some of these people in the preoperative period. So we
Right.
didn't see any people in the preoperative period. It's possible also that some of these patients got labeled as CLD, chronic liver disease, with very large spleens. And in contrast to the chronic liver disease with the very small spleens, we do see very large spleens in patients with chronic liver disease as well. And it's possible that they got misclassified as chronic liver disease, and therefore we did not pick them up. But this is the work that we've done. I think it's quite unfinished kind of work, but with the decrease in the number of patients with non-cirrhotic portal fibrosis, it's becoming more and more difficult to elucidate it. You see it occasionally in patients with extrahepatic portal venous obstruction. So if you'd see it in 4 out of 10 or 5 out of 10 in NCPF, you'd see it in 1 out of 15 or 20 in patients with extrahepatic portal venous obstruction. And the extent or the severity would be much, much less in patients with extrahepatic portal venous obstruction.
So does it mean that it's not entirely related to the shunt?
So yes, to us it seems that it's not related to the shunt at all, because it's been there prior to doing the shunt in these patients. So the patients with extrahepatic portal venous obstruction whom we looked at prospectively, preoperatively, 1 in 15 or 1 in 20 had some minor abnormality, small amount of protein in the urine.
So Piyush, whenever I met you, whenever I see you around in conferences, and that's where we normally meet now most of the time, uh, you're always occupied. You're always on your laptop doing something, a few minutes here, and then you open your laptop and start doing. So I often wonder that when and how do you chill?
Oh, currently it's very easy for me to chill. I have 2 granddaughters with whom I play, so I chill. I become a
So
child
what
all
did you
over
do
again.
at that time, all these 30, 43 years?
So there were lots of things. So actually, when I was working on my laptop, a lot of times there was something or the other which had to meet a deadline. Because of being involved with the journal, there was pending emails to be replied to from authors. There were reviewers saying I can't access, and so it was very mundane work. It wasn't very cerebral work that I was doing, especially when you saw me in between conferences, just utilizing my time more usefully. Very rarely was there something where I was trying to actually write up something, write up an article, analyze some data. I usually can't do that, but I would, having, taken care of the more mundane work, I would then have some time spare to sit down and actually do some more cerebral work. Um,
So what
I actually
non-cerebral things you do to uh, spend your time and get out of those uh, intense uh, mental exercises?
So there was a time when I used to sit down and listen to music. I used to read fiction a lot. I used to love reading biographies of people. I always wanted to know more about people, and those were things that I often did. Um, I think I've read through most biographies and autobiographies of surgeons who've
That's
written
interesting.
about themselves, and I I always had this keen interest in knowing about people. So today I can do it on my laptop. I don't do it at conferences and meetings. I can assure you that, because I like
So
to sit down, relax, and do it. I
are
do
we
it on a
going
flight.
to are we going to read soon a autobiography of Piyush Sahani?
Very unlikely, not soon. At some point in time, I'd like to sit down and write something, but not soon.
Well, so
Not soon.
I come to the last part now,
Okay.
which is, in that paper which you wrote in 94, there were patients with jaundice and then they were classified as having hepatitis and some other causes of jaundice. But I didn't hear or read about portal biliopathy or portal cavernoma cholangiopathy as it is called now. So you think at that time it was underdiagnosed? Because now when we look at it, it says that the incidence of cholangiographic involvement is three quarters almost in 75%, and roughly about 30 to 50 would have symptoms in their lifetimes. So you think that this was the entity which was there always, and we now came to know, and we were not able to attribute the real reason or have enough imaging modalities at our disposal at that time to diagnose these conditions.
So, in my opinion, so this is all. I don't have any evidence for it. I can't give you numbers, but I think the incidence of portal biliopathy is actually increased. Why is it increased? There are two or three possible reasons, and we don't know which one of these is true. Our patients are definitely living longer. Patients with extrahepatic portal venous obstruction are definitely living longer. And if they are living longer, then is this a manifestation of the fact that that inflammatory process in and around the portal venous system is continuing and therefore causing the inflammation to progress to the bile duct and therefore cause issues related to portal biliopathy, intrahepatic as well as extrahepatic involvement? That's one possibility. The other possibility is that we have a new modality of therapy which wasn't available at that point in time. And that is why we didn't see so many of these patients. And that is endotherapy. And endotherapy is used very, very commonly today. And is that the reason that this could be increasing in numbers?
The endotherapy, when you say you include both sclerotherapy and EVL, or you distinguish, have a
I
difference
think
in.
No, I think it's probably a little more with sclerotherapy, a little less with varicose banding, but it's still varicose banding does cause some amount of thrombosis. And when it causes thrombosis, there is a fibrotic reaction or an inflammatory reaction that tends to happen. And that process can extend along other portal venous channels or other channels which are connected to the portal venous system and cause the same problem. The amount of inflammation that you see in patients with sclerotherapy is more. You have extravasation of the sclerosant, you have ulceration, and so on and so forth. But you do see ulceration even in patients who have had banding done. It's not that it disappears completely.
Yeah.
The incidence comes down dramatically, but it doesn't disappear completely. So the same logic, it happens with all forms of endotherapy, but probably a little less uh, with
Banding.
banding than with use of sclerosants. So these are two possible reasons that we are seeing more of portal biliopathy. As a resident, we hardly ever saw a patient with portal biliopathy. Mm, there were those
I
occasional
would put
patients.
it to probably we were not aware of that entity. I mean, this is how
No, I think we
I
were
was
aware of
looking
the
at it.
entity. No, I think we were aware of the entity. We had these patients so I remember a patient in whom we did a Longmire procedure, who had what today would definitely be called portal biliopathy. And in fact, in those days, because uh, ARCP and all these things were not available, MRCP was definitely not available. In this
Yes.
patient, after having done a Longmire procedure, we got an intravenous cholangiogram done, a biloptin, solubiloptin study done.
Hmm.
So my impression is that it's not that we did not see them, we saw them infrequently. So there was a case report of a lady who had a distended gallbladder who then was found to have extrahepatic portal venous obstruction. For the distended gallbladder, because she had multiple other problems, she had only a cholecystostomy done, and then she had a shunt done, and then we wanted to take out the cholecystostomy tube, and somebody said, let's do a cholecystogram, and we did a cholecystogram, and suddenly the portal venous, the common bile duct was now nice and clean, and previously it was all ragged and irregular and had indentations in it. And those are some of the patients and these are times when we didn't have MRCPs. So it was not that we were not aware of the entity. We were aware of the entity, but we were seeing very few patients. We now see much more patients.
So, in your experience, how effective is shunt surgery in reversing the changes of biliopathy? I mean, we understand that there are various kinds of changes which we have: compression, nodular impressions, and then there are these strictures and all. But I want to know that efficacy of shunt in your experience for portal biliopathy, by which you would say that that's the end of treatment for portal biliopathy.
So again, unfortunately, I can't give you numbers. We did start doing the study, but then got interrupted because of various reasons. My impression is that in about half the patients in whom we do a shunt, we don't need to add a second procedure. The second procedure in some of these patients would be a stent, which is in situ, and any attempt to take out the stent results in an episode of cholangitis all over again. And the patient doesn't want another surgery and therefore has the stent in place for a long period of time. Some of these get converted to metallic stents and others remain with plastic stents and frequent changes. In the remaining patients who actually reach us because they're fed up of the process of having stents changed
Thinking.
every now and then, we would end up doing a hepatic angiogestomy. We all say in lectures and conferences that doing a shunt is a good idea before doing a hepatic angiogestomy. I think it is a good idea, but you still need to be wary. Just because you've done a shunt, it doesn't mean life is all hunky-dory. You can still get massive bleeding and you can still get a situation which may become irretrievable if you're not aware of it. And if you think that, there's a small amount of bleeding, I'll be able to manage it. Anyway have done a shunt, so I won't get into difficulties. You can get into difficulties. So one has to keep in mind the fact that a shunt is a good option, but using other adjunctive measures. So we always try and use hypertensive anesthesia, use terlipressin intraoperatively, try and decrease the portal pressure so that you don't get too much bleeding when you open up the bile duct. Don't put in sharp instruments blindly into the bile duct and try and pull out things which seem like soft stones, which actually are varices, and then you get a massive
I know
gush of
that's a
blood
nightmare.
coming out of the bile duct. So those are things, yeah, those are nightmares. And then, you just need to pack the bile duct and wait for a long enough time before you take off the roller gauze and hope that the bleeding has stopped, because you
So
just can't access those areas.
you made this point, and I think there's I mean, it's very relevant and important. But is there any way you determine that this is the right time to go, or this is the right situation to go in for the bile duct surgery? Is it only the time? Is it the local conditions and assessment of collaterals in that area? How do you assess these patients and say, now is the time to go and do the surgery?
So we would definitely give a time gap of 3 months before we would consider going in to do a hepatojejunostomy. So that is the time frame. 3 months definitely, not before that. Also, you need to give 3 months for the portal decompression to happen and for whatever amount of decrease of flow in the portal venous system, decrease of pressure in the portal venous system that's going to occur. So 3 months, yes, definitely. If in the intervening period a patient develops cholangitis, we would manage it endoscopically rather than try and intervene at that point in time. So 3 months definitely. At 3 months, we would try and assess as to whether we can give this patient more time. So I'm happier giving them more time for their portal pressure and portal flows to settle down. If the shunt is patent, we can definitely give them more time. If they haven't had a rebleed in that period of time, we can definitely give them more time. And if they haven't had an episode of cholangitis, we should definitely give them more time. The less the portal pressure and the better the portal flow across the shunt, the lesser the chances that you will get into difficulties in the intraoperative period. Now, if you're beyond 3 months and the patient develops cholangitis and has a stent in situ, then we change the stent and then offer a hepatic angiogestomy at that point in time. We would not wait any longer for that patient. But if we could defer it for a little more time, then anywhere from between 3 and 6 months before we decide to do something. The patient has gone past 6 months, not had an episode of cholangitis, we would, if they have 2 or 3 stents, we try and take out one, then a second, and then the final stent and give them a stent-free trial. If they are free of cholangitis on a stent-free trial, then we'd leave them there. If they get an episode of cholangitis, stent them again and offer them a hepatojejunostomy.
Any local things you see
So
pre
that's what we would do.
the MR or MR collaterals, and does it have a bearing in
Yeah,
your
so
decision
so
making?
we would, but if a patient has cholangitis, there's very little you can do, no? Even if they're more collateral. So we're mentally more prepared. We would tell the anesthetist that we might lose more blood. We would arrange a little more, instead of 4 units, maybe get 6 units cross-matched in the blood bank, and tell the blood bank we may need another 4 units. We may, but so we would definitely then use hypertensive anesthesia and do intraoperative depression. But if you have to go in, if you've got cholangitis, then it's best to go in rather
Yeah,
than, let it
best as
linger
a
on for too much. Yeah.
first case, good anesthetist, enough
First
help.
case, only case, good anesthetist, stand by another 1 or 2 small cases, but only on the condition that that's your lucky day and the patient's lucky day, and the God is kind to the patient, not kind to you, kind to the patient, so that you don't mess up with the patient and you have a good day. Just hope for that and pray for it.
Yeah, it's great. I mean, it is great talking to you, Piyush, on this uh, area of your work. And I think it's a very important area, and which people would like to listen to and understand from you. And I think you've done justice in that respect. And I've thoroughly enjoyed hosting you on this podcast. And hopefully, we'll meet again soon. All the best to you in your retired life. And thank you very much for consenting to join on this podcast.
Thanks, Sadiq. Thanks a lot. I've enjoyed talking to you, as I always do when we meet anywhere else. So it's been a pleasure talking to you. Thank you so much.